Hi, good afternoon, everyone. Welcome to our Unit 6 discussion here in ST135. Today we're going to be talking about robots and different endoscopic equipment. There's quite a bit to talk about with those topics today, so we are going to jump right in. So our objectives today are going to be to discuss the advanced technology of robots in the world of surgery and also kind of a subspecialty of endoscopy or endoscopic equipment as well. Anymore, a lot of facilities have these surgical robots. It's really kind of becoming the norm. So it's important as surg techs to understand the basics of robots and how it would pertain to you and your job here. So let's talk about our assignments real quick for Unit 6. We're almost to the end of this quarter, so hang in there. We're getting there. All right. So again, your typical discussion post due Wednesday. Don't forget to go back and respond to up here for full credit. Okay, you got a couple other little assignments here. But also let's look ahead to next week because this is Unit 7, Week 7. It's our last full week of this class, okay? Because Unit 8 is more of like a wrap-up reflection, and there won't be any discussion. You'll just have that last discussion post to wrap it up. So look ahead for next week, just because there's a lot of assignments due next week, and a couple of them are worth 100 points here. So I don't want you to be scrambling or get it in late. Grades close at a certain time, so I want you to make sure you get those in, okay? So plan accordingly, okay? All right, so let's jump in here. So robots are kind of a new thing. Did you know that laparoscopic surgeries didn't start until 1901? Really, in the grand scheme of things, that's not that long ago. In the scheme of medicine, you look back, that's not that long ago that we're really starting to get into this stuff. And robots weren't even introduced until the the 80s. I was born in the 80s. I'm going to show my age. So that's not that old because I don't want to be that old. All right. So robotic surgery started in 1985, and that was pretty limited back then, right? But in the last, I would say, 10 to 15 years, it's just exploded exponentially and has become pretty much commonplace to use robots in surgery. There are a lot of different types of systems now. I think, and I didn't look this up for sure, but I'm almost positive that the Da Vinci was probably the first. That was the big deal. We're getting a Da Vinci. It was the coolest thing to say your hospital got the Da Vinci robot, surgical robot. So that was probably one of the first most commonplace robots, I would say. Some of these are starting to gain popularity. This one up here, this picture at the top, is called the Versius. So it looks very similar in this case. Like the joint arthroplasty system is going to be a little bit more specific to arthroplasties, whereas, the Da Vinci Versius would be more for like abdomen, pelvis, those types of procedures. Yep. So let's talk about the different parts of the robot. What are the components to the surgical robot? So I liked this picture. I wanted to include it just to see how the room might be set up. Sometimes it's hard to envision, when you say robot, sometimes it's kind of hard to picture, what exactly that means. But you have this thing next to the patient over here called the patient cart or the bedside unit. Okay, it has both names that you need to know. That's where the instrument arms are attached to. Okay, and then it's going to be hooked up to the surgeon console. Could even be done remotely. You could have a surgeon in another place, telemetry essentially, where they could operate from another hospital, another country, if they really wanted to, which is just mind blowing to think about, really. So that's where the arms are attached here at this bedside or patient cart. Um, it just shows you a little bit of a up close picture of what some of these instruments look like. This one's called the endo wrist. It says they are designed with 7 degrees of freedom. So you'll hear that sometimes in that the way that this little arm moves at the end of the instrument uh, moves with 7 degrees of freedom. That is how the human hand works, that type of dexterity. So that's pretty cool. You'll have an assistant up here, even though the surgeon's over here working, the assistant, and this says nurse, that's going to be you, the surg tech, more often than not, will be up next to the patient throughout the case. because sometimes this circulator, or I'm sorry, not circulator, this surge tech will need to put different instruments attached to the robot arms. Sometimes those have to be changed out. So that's what you'll be there for. And if anything goes wrong, you're right there to jump in. So there's also going to be a vision cart for a screen. So whoever's a peer assistant surge tech can see what the surgeon is seeing at the console. Okay. So the console is typically going to be maybe in the corner of the room, maybe even in like a sub-sterile room, that's possible. That's typically where you're going to see those. Okay. So those are the main components to the surgical robot. Now let's talk about some pros and cons. I think at least it used to be that people dogged a lot on robots, like, it's not worth it. It's too expensive, or it takes too long. So, you got to weigh the pros and cons to anything. That's true of robots. As you as a patient, if you had that option, you need to weigh the pros and cons. The surgeon should be telling you the pros and cons to robots. It's not perfect. Okay, it's still probably got some room for improvement. Because if you look at some of these cons here, there's no tactile feedback. Sometimes that's a complaint from the surgeons. It's different than if you are holding that laparoscopic instrument yourself. You can feel some of that resistance, and I think that's what they're working on. Robot surgery is very expensive. The robots themselves are very expensive. The resources they require are very expensive. So a lot of facilities in smaller rural areas, that's why they don't have them. They just can't afford it. It doesn't pay off for them in the long run. So it also requires an on-site coordinator and the team themselves, not just the surgeon, but the surge tech, the circulator, anybody that's going to be in contact with that surgical robot has to have specialized training, because it's not something you just come in off the street straight out of school and know how to do, because it's very detailed, it's very specific and expensive. That does require special training. Some facilities may even require you to take a small course to get a little certification for it. So that will be dependent upon your facility. So some of the pros, the images are really good. They're in 3D. Typically, the patient does recover faster because there's less trauma to the tissue. The incisions can be a little bit smaller, or maybe even less surgical incisions. So typically they say faster recovery and maybe even a little less bleeding overall. Um, it has a way of reducing any tremor from the surgeon's hand, which is pretty cool. And I said this before, telesurgery is possible. You could have a surgeon in another country remotely somehow, it's mind blowing to me, come in and have their console hooked up to the one in the OR and work that way. Someone would still, I think, have to be available in the room or within the facility in case something happened, but it is possible. And it does closely replicate human movement, like with the dexterity of the instruments. So you just got to weigh the pros and cons. So I want to show just this quick video of this doctor talking about some of those pros and cons, a little bit about the robot itself. So hopefully it'll play here. Maybe.
Hi, my name is Matthew Sappington. I'm a general and bariatric surgeon here at the Kansas City VA. This is our Da Vinci robot that we've recently acquired here at the Kansas City VA. Essentially what it allows us to do is, while we sit at this console, we're controlling the different arms of this machine. And through doing that, it gives us more flexibility in how we operate as laparoscopic or minimally invasive surgeons. With the addition of the robot, we have the ability to essentially use the tools as though they have a wrist. And whenever we start the case, it starts very similar to our regular laparoscopic surgeries. But once we're on the inside, we have much more functionality to our hands. And so one of the things the robot adds to sort of our repertoire here is that it will give us a chance to do more of our operations in a minimally invasive fashion as opposed to an open operation. It also gives us the opportunity, I think, to do more complex operations that would be difficult to do laparoscopically. In general surgery, we're using it for a wide range of operations, from hernia repairs to gastric bypasses in terms of weight loss surgery, taking out gallbladders, other complex abdominal surgeries, including cancer operations. And eventually affords us the opportunity to accomplish some operations that are really in difficult areas much faster than we would be able to do it in a traditional laparoscopic fashion. Faster, easier recovery with less pain. The ability to do more open operations as minimally invasive surgeries with the Da Vinci robot means that we're going to have faster recoveries, less pain, and less bleeding.
So that just kind of gives you a brief overview of, some of the highlights. Like you said, it could be used for a lot of different types of procedures now. That even if it was strictly an open case, can now be done robotically, not even laparoscopically. So hopefully that helps you see it. If you've never seen one before, they're really cool to watch. So let's move on to endoscopy. So it's slightly different than robots. The term endoscopy, if you break it down as far as med term goes, you're viewing inside the body. That's what endoscopy truly means. So it's kind of a very broad term, and you can break that down by changing the location of the body. Like if you're using your med term, gastro, colano, lapro, that's telling you where you're looking. The oscopy part is to view, you're viewing inside of what? In this case, gastro is stomach. Now, typically we would call a gastroscopy, usually we're going to call it an EGD, which stands for esophago-gastro-duodenoscopy. So you're going to take the scope and go through the esophagus into the stomach and the duodenum. So typically that one's called an EGD, colonoscopy, excuse me. So look through some of these. They're all different parts of the body. So you have to understand your anatomy, what that means, where you're going to be working, and it's going to change the type of instruments that you need. It's going to change a lot about the procedure. So not all endoscopy cases are the same. Now, some facilities will have, sometimes they call it like an endoscopy suite or the endoscopy part of the OR. In that case, they will typically do your EGDs and colonoscopies there. It's kind of a little more specific to those types of cases, and they'll have those machines for the scope hookups there. Okay. The rest of these can be, any of them can be done in a normal OR, but you typically wouldn't see an arthroscopy in an endoscopy suite. So it is a little tricky in that instance. Okay. So like I said, the endoscopic, man, struggling today. Patient preparation, special considerations. It depends, like I said, on where the anatomy is, what you're working on. So you need to know ahead of time the name of the case, the patient anatomy, be thinking about, okay, if this is a thoracoscopy, we're going to be working in the thorax. We're going to go into the chest with a trocar, a scope. So what kind of positioning might be needed? What type of anatomy am I going to come in contact with? How do I position, which means it affects how do I prep? So lots of different things, different areas. If I'm working in the pelvis, it's going to be much different prepping and draping than if I'm working on the chest, right? So keep those things in mind. Also here, I want to point this out. Anytime, even robotic, endoscopic or robotic cases, you need to always, in your head, be prepared to convert to an open case. That is always an option, and it's always a potential maybe emergent thing that happens. Maybe the surgeon accidentally nicks a large artery and they're bleeding excessively. They can't get it under control. They may have to open that patient up. Things happen in surgery. Surgery does not always go as planned because human error, or it could be the patient's anatomy is just different. You might not see a typical artery there that, isn't always there. Things happen. So be ready in your head to always convert to an open case. So most facilities are going to have a tray of instruments maybe on hold in your room that would be available to you to convert to those open cases. So, if you're doing a laparoscopy, you're just looking in the abdomen. You will probably have a laparotomy tray. That's going to be your basic hemostat, Kelly, Alice, Babcock, Cooker, your scalpel, all of those retractors to convert to that open case. So it might require you to also count those items. You may have to switch out your Ratex for lap tapes, laparotomy tapes. And those conversions from closed or laparoscopic to open can happen very quickly. So always have your blade ready, always be able to switch out your instruments as quick as possible and let that surgeon get access with the blade. Have hemostats ready, Bovie, those types of things to control bleeding. Okay, so I just wanted to point that out to you. So some of your endoscopic equipment is slightly different than your robotic, okay? And depending on the type of endoscopic case, you might have a few different things here. Now, like, for example, the arthroscopy wouldn't have an insufflator. They're going to have something more that would have a way to use fluid to open the cavity to see. So sometimes if we're doing endoscopic cases, you're using that trocar to get into that cavity, that space. Maybe it's the abdomen. You need to be able to see, and you need to expand that space a little bit so you can see better. So it's not just like everything squished on top of each other, okay? Like this picture here, it's so all the anatomy is kind of open because we have what's called insufflated the abdomen. We have put in carbon dioxide, CO2, into the abdomen through this machine called an insufflator. Okay, when there is that carbon dioxide in the abdomen, that is called pneumoperitoneum. So you create pneumoperitoneum with CO2 through insufflation. Okay, there's a little piece of equipment or like a needle called a Veress needle, V-E-R, I think it's 2 R's, V-E-R-R-E-S-S, Veress needle, that you use to hook up to your gas tubing that goes to the insufflator. That way you can see, kind of blows up the abdomen like a balloon a little bit. The pressure stays within 12 to 15 millimeters of mercury, typically mmHgs. That way it doesn't over insufflate. You're going to have a light source so you can see it's dark in there, right? You have to have a light source. And then you're going to have a camera that gets put into one of the ports so the surgeon can see what they're doing, which is going to be portrayed on the monitor. And there might even be monitors pre-hooked up that hang from the ceiling in the OR, multiple monitors. One of them is actually called a slave monitor because it just mimics what this one does. Okay. So sometimes they will record the entire procedure. So there might be a recording unit. There might even be a printer. A lot of surgeons like to take pictures that they can put in the patient's record or make copies and give to the patient. So a lot of times they'll print off pictures of anything they took out or any abnormalities so they can show the patient what's going on. They'll also most likely, if not on this card, a separate one, have what's called a diathermy, which is your monopolar, your bipolar, ESU cautery hooked up with that. And sometimes they're on this roller stand that could go between rooms, or it could be stationary in that room, depending on your facility. Okay, so it does vary on procedure. So not all of these things, depending on the type of scope you're using. Okay, so your scopes use ports. That's what goes into the area, whether it's the abdomen, it could be you could do a knee scope, a knee arthroscopy. Those ports are going to be smaller than what you'd use in the abdomen. So make sure you have the right type of ports, or sometimes they're called trocars, right? So that's basically it for robots and endoscopic equipment. If you have any questions, please reach out to me. My email is nludwig@herzing.edu. So you guys are really good about reaching out if you have questions. I'll get back to you. do you have office hours on Tuesdays, or, we could work something else out of that if you need to do that. All right. Have a great week. We're almost done. Hang in there.